we are here again at the main EAU event of the year, the main congress here in Paris, the City of Lights, and it is a pleasure to, dear colleagues, to have with us Professor Gillessen from Switzerland. Today we had an impressive session, the joint session of EAU and the Advanced Prostate Cancer Conference session. The room was packed, there was a lot of discussion, and I think overall two themes were debated. The first one was about metastatic hormone-sensitive prostate cancer. There are a lot of novelties, also radiation and a bit of surgery was discussed today. So what were the main points that were highlighted during the session, and what are your thoughts on the discussion that underwent today?
Yeah, so maybe I start. So first of all, I think it's really fantastic that EAU has this close collaboration with us, with the APCCC, the Advanced Prostate Cancer Consensus Conference, because I think it's really important that we have a lot of urologists on board, because they are so important, as we discussed right in this multidisciplinary treatments that we have to do now, or that we do now, kind of every day, right? So the metastatic session we focused on low volume de novo disease, because that's something, that has a lot of dynamics right now, because we are using more and more PSMA PET, as you know well. So it's a bit different from country to country, I realize, right? So in Switzerland, we have quite free access. I think other countries, like especially also in the States, what is always very surprising, it's not so easy to get PSMA PETs. So I think but it has really changed our practice, because now we're seeing much more metastatic patients that probably 5 years ago with a conventional imaging would have been negative. So now how are we treating these patients? Are we treating them like M0 patients? Because I mean, all the trials that were done with conventional imaging, or do we say biologically it's probably more important that when we are sure that we see metastasis, and we should treat them like metastatic patients? And I think this is like one of the big questions, and we discussed a lot about that. Also, can we maybe in these patients give kind of combination treatment, and then make a treatment break when they respond very well? So I think that there was a lot of discussion also about that, and that's really a topic that's also close to my heart, because we know long-term ADT is inducing a lot of side effects, metabolic side effects, osteoporosis, and so on. So if you could find out who are the really good patients who respond really, really well to therapy. Larry Klotz was standing up and was saying maybe they have to really go to zero, and then you could maybe also discuss with the patient to make a treatment break. We don't have the trials yet, but for the combination treatments, but I think it's quite interesting, and there was a lot of discussion on that one.
Okay, thank you. Yes, today is always nice to see from one year to the other how this topic is incredibly evolving, and now we are all merging together. Now it's a team effort. Prostate cancer is not anymore a problem for the urologists or just for the oncologists, right, or the radiation oncologists, but we all have to join efforts in this sense. And of course, giving a break from ADT plus minus other systemic treatments would be beneficial for the patient. And also PSMA has a huge interest. We saw today, I think, there is just one study at the moment with surgery retrospective evidence that has some molecular imaging. All the others have conventional imaging. That was also interesting. Another point that went out, which is also interesting, that although the amount of false positive in PSMA is low, we also have some false positives. So this was also another interesting thought, because it's not 100% for PSMA lesions.
I totally agree with you, because always when we have something new, we think it's 100%, right? So and it was really very good that we had, I forgot who showed the data, I think Nicola Fossati, that no, it's not 100%. It's better than bone scan and CT scan, but it's also not perfect. So we have to stay critical. And, we have to discuss with our nuclear medicine colleagues, right? Exactly. Because I think, as you said, we are really used, I think, to talk multidisciplinary with, the urologist, the radiation oncologist, the med-oncs. But then now, I think, the circle is much larger now. The nuclear medicine specialist comes in, the MRI specialist for specifically the prostate, but then also the whole body MRIs that are done in some centers. So I think, the team gets bigger and bigger.
Of course, and then genetics, pathology, right. So it's getting more and more complex and more personalized. So I think that was the main point of the discussion. This was very well highlighted. And talking about PSMA in new molecular imaging brings us to the second topic, in which PSMA was discussed today, in which PSMA is also very, very important because it's revolutionizing recurrence. And the other big topic was PSA persistence after surgery. What were the most interesting thoughts that were discussed during the session, in your opinion?
So Derya Tilki gave a really, really brilliant talk showing us the definitions and the importance of PSA persistence, right? Because I think it's quite impressive that PSA persistence after radical prostatectomy is a very, very important prognostic factor, and it stays an important factor also in the multivariate analysis. So I think, something, we should have that in mind, right? If a patient has a PSA persistence, probably his prognosis is less good than in another patient. And then there was a lot of discussion how we optimally treat and diagnose these patients. If they haven't had a PSMA PET maybe before the operation, I think this would be the first logical step to do, right? But a lot of our patients, at least in Switzerland, had already the PSMA PET directly before the operation. So there it gets already more complicated, because one of it was a very good question from the audience. Someone was saying, but the PSMA PETs are expensive. Also, there's irradiation involved. Then there's logistics. There's some countries where you can't get it so easily. And he said, so what is the best time point, right? So we don't want to do it every 2 months, right? Because the PSA is rising, and then you think, maybe we do it again.
It's negative, and then, okay, but let's wait, maybe we can do it again. But then
I think that was quite a good question, So does it make sense to, then say, okay, I exaggerate now a bit, every 2 months to make a new PSMA PET? Probably not. So I think that was some very interesting questions. In the end, we don't know how to treat PSA persistence optimally. So Nick James gave a talk about what could you do. And I think what we have to keep in mind is that we have also there to be personalized. Not one patient is not the same like another patient. The PSA doubling time is maybe much faster in one patient than the other. Some patients maybe have a really high PSA already after the radical prostatectomy. Others, the definition is more than 0.1. So they're just on the limit. I think, we have to also there really be more granular and try to be personalizing. But in the end, it was quite interesting that we actually don't know if we should treat in that moment. And Nick James, in his side as a clinical oncologist who does also radiotherapy, he said for him is very important what was shown in the radical prostatectomy. So was there a margin? Was there a large margin? Was there PN plus disease? So did you find lymph nodes? But then obviously in some countries like the UK, not always a lymphadenectomy is done. So I think, there were a lot of questions there. You know better than me about.
Yes, it's a complex subject, and it's really diverse because of a combination of lymphadenectomy, which is done more in one country compared to another, PSMA, as you just mentioned. So the nice thing today was to see that we have some agreement to start with, which is the definition, because the majority of studies say 6 weeks, 0.1, so we had an agreement, but then what comes after is extremely diverse, because you can have a patient that is recurring systematically, a patient that has a localized recurrence, a patient that has localized recurrence in the nodes. You can see the recurrence, you cannot see the recurrence. So we know the definition, we know its influences. It's a bad prognostic factor because it relates with cancer survival and with overall survival, but we are still having to find our way on personalized medicine in this setting. And to conclude, our last question is what do you think are going to be the hottest topic you're going to discuss and you're looking forward to discuss in the in the upcoming meeting, which is going to be, by the way, at the end of April?
Yeah, so APCC is 25th, 26th, and 27th of April, so I hope a lot of people register. So for me personally, I think, we have some, I think, really important topics that usually are not getting discussed so much, like side effects, for example. With now the EMBARK study, I guess we will give more enzalutamide monotherapy. I think you as urologists have given maybe more bicalutamide 150 milligrams, and you have already some experience. But we have seen in the studies that the gynecomastia and the gynecodynia, so really having pain, is a problem with enzalutamide as a monotherapy. So interestingly, in the EMBARK study, the combination, the LHRH alone versus the enzalutamide, all of it had toxicity. So enzalutamide didn't have so much less toxicity. It had different toxicity.
Different kind of.
And of course, the sexual function was better because that makes sense in the monotherapy arm. But I think now we are really seeing new or old new side effects that we have to think how to treat them. And I think that's quite important. And also, the knowledge that we now gather that the hormonal treatment really induces a lot of metabolic problems, cardiovascular problems, fractures. And the good thing is that our patients live much longer with metastatic disease, but for that also they can experience these long-term side effects. So we have to really try to take good care of our patients also, to manage the side effect profile.
This is a very good point, because now we are treating patients, but we do not just have to think about their cancer to be cured or their life expectancy to increase, but of course, quality of life, very important subject.
Very important.
Okay, thank you very much for being with us. It was very nice to discuss and to have a summary of the interesting session of today. And thank you again for being with us. And thank you, colleagues, for listening.